translation. And we are recording, so colleagues who are unable to be with us today can actually take advantage of streaming the session when it is finished. That being said, I want to make sure if you are interested in using the interpretation, the translation function of Zoom, please go down to the button at the bottom of your screen. We have 2 languages available for interpretation today. We have Spanish and we have Bahasa. Please click on your preferred language. And if you want to listen in English today, click on English. And that way you'll be able to use the channel and the language that you prefer. Likewise, we also have live captioning available. Again, that should be at the bottom of your screen if that would prove useful. That being said, can I go to the next slide, Adam? What we want to do is remind you that the Zoom functionality has 2 important buttons. One is the chat box, which you can see here, as well as if you prefer to raise your hand and make a real-time contribution. If you want to do that, you will find it under the Reactions tab where there is the raise hand icon. In the next slide, let me remind you of the virtual norms we are embracing to get the work done in this session today. The first is we trust you will be fully present and engaging for the next hour and a half. We'd love for you to be authentically curious, asking questions to learn more. And then this one's kind of important. Could you keep yourself on mute if you're not speaking? It helps us manage the ambient background noise. Likewise, if you are able to, if your bandwidth sustains, could we ask you to keep your webcam on? It helps us to feel that connection as the session unfolds. If we go to the next slide, let me share with you what our session objectives for today are. Today, you're going to get the chance to hear highlights of how UHC-oriented reforms offer an opportunity to reach those global nutrition targets. We're going to look at concrete strategies on how health financing levers can actually improve effective coverage of nutrition services. And last but not least, really look towards future actions in order to position nutrition within UHC, better integration of nutrition into health systems, and truly promote data-driven accountability, securing effective and sustainable financing for nutrition. This is a juicy, substantive session we have for you today. Finally, before we turn to our esteemed speakers to get us going, this is the overview of our session. I will not read it to you, but we are going to have some exciting presentations, both around a discussion paper you'll be very interested in, as well as some wonderful colleagues from the field offering insights. We're going to give you a chance to go into breakout rooms for more kind of smaller discussions about what you've been learning, and a final Q&A before we close out the session. So with that, if we go to our next slide, I am delighted once again to turn the floor over for our official welcome to session 2 to the Global Director of Health, Nutrition and Population and the Global Financing Facility, Juan Pablo Uribe. Juan Pablo, it is a pleasure once again to turn the floor over to you. You're so welcome.
Laura, thank you, and the pleasure is mine. Good morning to everybody. Good afternoon. Thanks so much for joining and for your efforts in nutrition, such an important area for human capital, for human development. As Laura said, this is the second day of this very special Nutrition Financing Week. I do want to start by appreciating and recognizing the effort of all those of you who have been organizing these events and getting us together around such important topics with such a good content. I also want to highlight the co-organizers who come together to support this week. And I'm talking about the Republic of Indonesia, the Joint Learning Network, WHO, the Bill and Melinda Gates Foundation, Results for Development, and of course, also the World Bank and the Global Financing Facility, GFF. So to all of them, thanks so much for this great partnership. Today, as Laura was saying, we're going to have really interesting, I would say, interacting space where we can work to strengthen nutrition financing at the country level. And it's the space that is created as we push and advance universal health coverage. It must be said that during these last 2 years, and the annual global report from WHO and the World Bank show it like that, many countries have backstepped, unfortunately, due to the crisis and progress being made towards universal health coverage. So as we, with optimism, walk out of the pandemic, hopefully in the coming months, we need to readdress this huge goal of guaranteeing universal health coverage with access to healthcare services, with financial protection for households, and ensure that we take that opportunity to strengthen and mainstream nutrition in the core of progress to universal health coverage. It has all to do, by the way, with strengthening primary healthcare, as we will be working strongly in. It has to do all with coming back with essential health services, where nutrition has to be on the top list of those services. And of course, it has all to do with a sustainable and longer term health system strengthening agenda. I'm here talking about very concrete actions that we can look at the country level, again, within the different models of advancing UHC, but always bearing in mind the importance of nutrition, again, in the top part of the health agenda. And I'm talking about being able to identify those concrete nutrition essential services that have to be in what many countries call the basic health packages that we try to prioritize and guarantee for all. It has to do with looking carefully at domestic financing, the efficiency, the flow, the expenditures, how we track those. It has to do in many countries coordinating other financial flows from outside, from donors, from other sources. It has to do with the data and tracking systems for financing flows, again, and how we make those accountable and visible and ready online. And it also has to do, as I said at the beginning, with system strengthening, building institutional capacity, building sustainability, and ensuring throughout the way governance. So it's again, a very important agenda, a very challenging agenda, but one that we cannot miss as we come again from these difficult years. I just want to end recognizing the importance of having the experience of Indonesia and of Rwanda today here with us, two countries leading by action in terms of nutrition strengthening for their citizens. So to both Mr. Buhari Ali and to Mr. Felix Sajingsoga, all my appreciation for your collaboration and for sharing your experience and your knowledge with all of us. With this, Laura, going back to you, wishing everybody a very successful session where we again engage and we come out of it motivated to work strongly in our countries in improving nutrition for all. Thanks.
As always, thank you, Juan Pablo. Wonderful words to get us started, and we are delighted. Our next speaker, really setting the stage and moving us forward in our work today, is Dr. Francesco Branca, the Director of the Department of Nutrition and Food Safety from the WHO. Dr. Branca, you're so welcome. Thank you.
Thank you very much, Laura, and good morning, good afternoon, good evening to all. It's a pleasure to be with you today. And I'm really thankful to the Global Financing Facilities and the World Bank to have worked with us in the preparation of this very impactful, I would say, week of discussion. I really would like to start with the point that malnutrition in all its form is really one of the world's leading causes of death and illness. Even before the COVID-19 pandemic, the world was off track to achieve the global nutrition target for 2025 set by the World Health Assembly. And COVID came and made things worse. And we've calculated that still in 2021, 41% of the countries reported some disruption in the services, for example, to address moderate and severe malnutrition. And that is one of the highest level of disruption among all health services. And this disruption still stay there. But this for nutrition services goes on top of a very difficult level of delivery of the system. The coverage of nutrition intervention in healthcare lags far behind the coverage of traditional health non-nutrition services. So just to give an example, while half of the children with diarrhea receive oral rehydration, less than 1 in 6 receive zinc supplementation. And while 2/3 of pregnant women have access to antenatal care, only half of them receive iron and folic acid supplementation. Furthermore, nutrition services may be managed by external development actors and are not integrated in a continuum of care. And this is the example of wasting management. We have also flagged insufficient investments. In the 48 countries for which we have data, the average government expenditure was $1.87 per person. And it is the lowest among all disease categories. And then the insufficient capacities, the number of nutrition professionals per 100,000 population. So clearly, we need to mainstream and prioritize nutrition in the primary healthcare benefit packages. Nutrition for Growth has been a tremendous opportunity, and we are really grateful for the leadership of the government of Japan to have decided to prioritize universal health coverage. We were very privileged to have an incredible group of activists as part of the working group on nutrition in universal health coverage, the UN group, World Bank, several NGOs. And this group, in preparation of Nutrition for Growth, developed a commitment guide with a series of asks, very clear asks, indicating the critical value of nutrition for universal coverage. Just to mention some, reinforce nutrition as a pillar for universal coverage, tailor to the country context, cover the whole life course, and really particularly the periods most sensitive to good nutrition, and then dealing with the multiple forms of malnutrition. So basically proposing a bit of a paradigm shift in considering nutrition services. And I think this has been particularly impactful. I mean, the whole process, took a little bit longer because of the pandemic, but eventually, having had more time was meaningful. And, the advocacy paid off. 67% of the 396 new commitments were on health, and several were really responding to the call to action made by the commitment guide. So this is the right time to intensify our action. And so again, I'd like to thank Global Financing Facilities and the World Bank for convening the meeting today and for preparing also the excellent paper, which I read with pleasure, we're going to hear today, Positioning Nutrition with Universal Health Coverage, Optimizing Health Financing Levers, which is giving very practical advice on how to translate many of those commitments into practice. I think the how is what we are now mostly concerned with. So we look forward to working with you all on this agenda, and I really look forward to listening to the conversation today. Thank you.
Dr. Branca, thank you. What a pleasure to have you again help welcome us and really ground the work that's to be done in this session today. We have one more esteemed colleague we'd like to invite to really make us feel welcome and to set the stage for your work. And that's Mr. Takahiro Tsuda, the alternate executive director for Japan with the World Bank Group. Mr. Tsuda, please, you're so welcome.
Thanks, Laura. Good morning, good afternoon, and good evening. First of all, let me thank all of the staff from the government Indonesia, Gates Foundation, World Bank, GFF, WHO, Reserve for Development, and Joint Learning Network, who are duly involved in organizing this great event. As you know, the Tokyo Nutrition for Growth Summit last month was successfully concluded. The participants were committed to taking further actions across 5 different areas, namely health, food, resilience, accountability, and financing, to end malnutrition in all forms by 2030 as part of the SDGs agenda. This is clearly slated at the Tokyo Compact on Growth Nutrition for Growth. On behalf of the Japanese government, I'd like to thank everybody for this great achievement. Last month, we saw another progress on nutrition through the IDA 20 replenishment in the World Bank Group. Human capital is newly introduced as one of the 5 special themes, and of course, maternal and reproductive health and nutrition services are included as part of the key policy commitments under this special theme. I proudly say that through the negotiation process, Japan has played a leading role in advocating the importance of these issues, in particular in the context of long-term health system, including universal health coverage, beyond the short-term pandemic response. So to tackle against malnutrition around the world, the question is not why, because it is already widely recognized, but the question is how. In this context, the whole of government approach is critical so as to maximize the value for money of each nutrition project. For instance, health ministries are in charge of designing high-quality nutrition policy. Finance authorities have a responsibility in securing financing resources and designing their efficient use. Development ministries are also helpful to prioritize the nutrition agenda at the center of the national development strategy. Subnational governments may be in charge of delivery of nutrition services in each local district, and so on and so forth. So how to make sure such collaboration within and even outside of the government? We must learn from each other. That is the reason why today's session is so valuable, because we will listen to leading examples on how each country optimizes how financial levers in well-tailored, innovative, and proactive manners. Indeed, I just like to echo from Pablo and Francesco that our mantra should be commitment to actions. Let me say a final word. Ending malnutrition is not an easy task. All the development partners, recipient countries, civil society should work together to tackle this challenging but rewarding task. Japan remains open to every single opportunity to pursue this endeavor further. I'm looking forward to a lively discussion today. Thank you very much, and back to you, Laura.
Mr. Tsuda, thank you so much, and what a wonderful call to action that the work here today will align around. Let me move us forward, because I think Dr. Branca gave us a great preview of what's to come. I am delighted to hand the floor to Ms. Kyoko Okamura and Naina Aluwalia, who are going to be sharing their work, looking at it's a discussion paper, actually looking at the forgive me, I'm focusing on the name of the topic. The discussion paper, I'm going to call it that. And I know that they are going to be offering you insights that are going to prove useful to the conversation that we have ahead of us. So please let me turn the floor to Kyoko and Naina. Both of you are so welcome.
Thank you, Laura. Thank you, Juan Pablo, Francesco, and Mr. Tsuda for really inspiring opening remarks that also demonstrated the growing partnership on this very important area of work. We will now present key findings from our brand new paper, Positioning Nutrition Within Universal Health Coverage, Optimizing Health Financing Levers. This is a joint publication by the World Bank Group and GFF, and WHO provided invaluable inputs through a peer review process. I would also like to express our appreciation to Japan for financially supporting the work through the Japan Trust Fund for Scaling Up Nutrition. Next, please. So first of all, let me share how we started the work. Malnutrition poses high social and economic burden on the health system, but nutrition services that are often preventive and promotive in nature are less prioritized in global and national actions to achieve UHC. It is time to reposition nutrition within the UHC framework and strategies when countries are investing in UHC reforms. We know what nutrition services we need to invest in and why they are important, as Francesco and Mr. Tsuda reiterated. But there has been insufficient focus on how to leverage UHC platforms for nutrition outcomes. And we felt that there are knowledge gaps to fill regarding how to deploy resources more effectively to deliver quality nutrition services and ultimately achieve the results we are committed to achieving. Next, please. So where do we see the opportunities? We specifically looked at the key health financing levers of revenue raising, pooling, and purchasing through a nutrition lens and examined potential ways of optimizing those levers to help address many service delivery and financing challenges that are affecting the provision of nutrition services. When applying a nutrition lens, countries can improve equity, efficiency, and transparency and accountability, which should lead us to achieving the goals of the UHC scheme, which in turn help achieve the impacts. We'll share specific actionable recommendations on how these levers could be optimized in the latter half of this presentation. Now, before moving on to the next one, let me quickly point out one disconnect in this impact pathway. The UHC monitoring framework that tracks the progress on key service coverage has no explicit nutrition indicators that makes nutrition invisible in the health system accountability to UHC. Such numbers staying implicit does not help the cause of the nutrition community, nor the UHC. This is one of the examples, and there are other areas we think are critical in making our health system more explicitly accountable to nutrition results. Next one, please. Now, let me quickly touch on the approach we took for this analysis. Since this is an emerging focus within UHC, there was insufficient literature to examine the impact of what has already been done. So we focused on unpacking countries' UHC reform initiatives and the work behind them to lay out financing challenges that affect nutrition service provision and possible solutions and opportunities that may benefit other countries from considering. This is an example of Indonesia, which you will hear more about in the next part of the session. Next slide, please. Next one, please. Now, to share our key findings, you have gone too far. Can you go back? Yeah, thank you. Now, to share our key findings, let me start with top-line strategic drivers we found are critical. First, we need a costed and well-defined nutrition package of services explicitly included in the national UHC framework and strategies. Second, we need better integration of nutrition services with the broader health system, including in the functions of health financing levers of revenue raising, pooling, and purchasing. Third, what supports the optimization of health financing levers is the strategic investment in health system enablers for nutrition outcomes, such as the data systems. Fourth, we need strong and explicit accountability measures in order for the health financing levers to function and ensure that nutrition services are delivered when and where needed. So let me now turn to my colleague Nena to share more detailed actionable recommendations under each lever. Nena, over to you.
Thanks so much, Kyoko, and to our esteemed speakers for laying out why this work is critical and timely, and for introducing the opportunities for using health financing levers to reach global nutrition targets. So as Kyoko explained, all these strategic drivers are highly interlinked. They drive each other sort of like compound gears, as you can see in the graphic, compounding the impact of nutrition service coverage and quality. So while creating a benefits package of nutrition services is critical, its implementation can be significantly improved with good accountability mechanisms in place. A functional enabling environment with predictable financing can further add to the effect. All these are crucial for enhancing nutrition service coverage and quality. However, a whole lot of this actually hinges on strong integration of nutrition within the broader health system. Next slide, please. So one powerful avenue for integrating nutrition services with the broader health system is aligning nutrition objectives with health financing arrangements. This entails optimizing revenue raising, pooling, and purchasing levers to address underlying financing and service delivery challenges for nutrition. So for the next few minutes, I'll try to quickly cover some actionable recommendations for each of the financing levers. Next slide, please. So starting with revenue raising, our first actionable recommendation is to strengthen evidence-based planning and resource allocation via systematic priority setting processes. Evidence should include disease burden of nutrition or diet-related risk factors, cost of nutrition interventions at both national and subnational level. There are several budgetary analysis tools that can inform resource allocation and improve efficiency gains and nutrition outcomes, such as the Optima Nutrition Tool, WHO Choice, which uses cost effectiveness, One Health tool, which provides cost and impact of different scale-up scenarios, and more recently launched Health Interventions Priorities tool, or the HIP tool. It is important to note that this use of evidence would also entail securing buy-in of subnational and local governments in decentralized settings. Our next actionable recommendation is on instituting innovative fiscal policies, such as diet-related taxations that can have a dual effect. There is going to be a session on this tomorrow, so a quick plug for that. But these innovative fiscal policies have a dual effect, which is first to incentivize healthier choices, in turn improving health outcomes, and second, to mobilize additional resources that can support the delivery of preventive or promotive care, including nutrition. So focusing on the resource side, it is also recommended to bring various funding sources on budget as much as possible and support the use of the resources with strong public financial management to increase predictability in flow of funds. And all of this can really help address service delivery challenges around stockouts, salaries, and contracting with private providers. And given the point in time that we are in, it is also important to advocate among budget decision makers the need to mitigate secondary impacts of the COVID-19 pandemic, resulting from the shift of focus and resources from essential health and nutrition services. I will not be able to go into examples because there is so much to share with you, but we will be doing country spotlights where hopefully you will see how this plays out at country level. And of course, these examples are quite well captured in the discussion paper itself, which I hope you will have an opportunity to go through. Next slide, please. So moving on to our next financing lever, pooling. So for pooling reforms, a significant objective tends to be to enhance redistributive capacity between pools to spread risk and for better equity. So our first actionable recommendation for pooling is to reduce fragmentation from multiple pools. So we can do this either by merging nutrition financing sources, including external financing, to increase the size of the pool and diversity and diversify risk while being cognizant of equity. Where pools can't be merged, enabling cross-subsidization between pools can allow for redistribution as needed. However, for this, there needs to be a few things that need to happen. There needs to be harmonization of benefits and purchasing arrangements to even out per capita funding, benefits, and conditions at the point of service. And then finally, another aspect of reducing fragmentation is bringing off-budget donor funds on budget. The next recommendation under pooling is institutionalizing regular nutrition budget analysis through an integrated financial management information system, or IFMIS. And IFMIS would have resource mapping and tracking across sectors and levels. And this can inform pooling reform that can improve coverage of nutrition and other preventive promotive services. There are tools such as Optima that can help determine allocative efficiency of pooling levels aligned with population needs. Next slide, please. So on our final lever, purchasing, our first recommendation is to develop an explicit, costed, and systematically prioritized nutrition package of services and include it in the nutrition UHC benefits package. There, more integration. Let me break this down a little. By explicit, we mean a package with, say, a positive list of services. In addition, this package should clearly specify nutrition services and define required conditions for quality delivery. Costing, of course, is critical, as Kyoko already pointed out in one of the drivers. A systematically prioritized package will be evidence-informed while taking into consideration factors like disease burden and cost effectiveness of intervention to determine what services should be included. And finally, integration with the UHC benefits package would be key. Integration can enhance the purchaser's ability to make strategic choices where funding can be linked to the performance of providers and the needs of the population served, and prioritize cost-effective, preventive, promotive services. One important part of this would be to harmonize benefits and payments at the point of service to minimize conflicting provider incentives from fragmented revenue or pooling streams. This leads me perfectly to our next recommendation, which is to create adequate incentives for providing preventive and promotive care. Reforms that shift input-based purchasing arrangements to those that are output or performance-based can create the right incentives to reach nutrition service delivery related goals based on performance targets such as quality, geographic, demographic, targeting, etc. Further, a mix of output-based payment methods can be considered to optimize incentivization mechanisms for nutrition service provision. Provider contracts can include provisions such as staffing and equipment requirements that can improve quality of nutrition care. And of course, monitoring is key to be able to see if the incentives are working, and therefore strengthening information systems to enable transfer of both financial and clinical performance data related to nutrition between providers and purchasers can be incredibly helpful. Since nutrition services are significantly provided by community health workers, reducing barriers to contracting of community-based providers is important to increase utilization of nutrition services. Next slide, please. So finally, there are some cross-cutting recommendations. You may recall that these already came up, but they deserve mention as they have implications across the health system and financing levers. So first, promoting the culture of using evidence to make decisions on budgetary allocation is critical. Evidence should include disease burden, service delivery, and costing. Second, data, but within an integrated, interoperable information system can be a very powerful tool to support decisions for multiple things, such as proper planning, which is responsible to population needs, holding providers accountable, and determining appropriate payment methods, to name a few. This can be highly effective where tracking and seamless exchange of financing and programmatic data is possible. Next, regular, reliable, institutionalized resource mapping and tracking can optimize strategic resource allocation and, where needed, course correction. And finally, a shift from input-based budgeting and payment methods towards one that is output-based can allow more focus on allocating resources to meet nutrition targets and better accountability for improved health and nutrition outcomes. I know that was a lot, but we will shortly be listening to country examples and going into breakout sessions where we will have opportunity to discuss and do a deep dive into some of these financing levers and approaches to leveraging and optimizing them for nutrition outcomes. But with this, I will hand over back to the facilitators. Thank you.
Thank you so much, Naina and Kyoko. We are so grateful. And if we go to this last slide, it is an appreciation and gratitude that says thank you for your discussion paper, Positioning Nutrition in UHC. As you've already heard, we again are very fortunate to have some esteemed speakers from the field who are going to be sharing their work and their perspectives to further inform where we're headed. That being said, I hope you noted in the chat box, I asked all of you, as you're having questions, whether it's about the discussion paper or what our speakers are offering, please make a note of those questions, as well as reactions or reflections. When we finish this next lightning round of presentations, we're going to have the opportunity to actually invite you into breakout sessions where you can pose your questions and share your reactions and input. But with that being said, I'm going to invite my colleague Adam to once again put up the slides, because we're going to move to these lightning round of presentations and have a chance to hear from our colleagues from the field. And so first up, and we are delighted to welcome him back, we are going to invite our colleague, Mr. Punkas Baduri Ali, from the Director of the Public Health and Nutrition in the Ministry of Planning in the Republic of Indonesia. And what we're delighted about today is Mr. Pungkas is going to take about 5 minutes to share thoughts on the experience of Indonesia in incentivizing districts to implement nutrition programs through fiscal transfers. Mr. Pungkas, welcome back, and we are happy to see you.
Thank you, Laura, for the opportunity. I believe that my slide is already on the hand of the organizers. You can put up my slide, please. Thank you. All right, good evening, everyone. It is a pleasure to speak again at this N4G Financing Week today. I will share about the experience of Indonesia in providing fiscal transfers to the district governments to ensure the implementations of nutrition programs. So we started this fiscal transfer scheme for quite some times, but we specifically dedicated the standing transfer fiscal from 2019, working hand in hand with the Ministry of Finance. Fiscal transfers program in Indonesia holds a critical role. Beside the fact that Indonesia has a decentralized systems, there is also a high disparity in fiscal capacity among districts. Yeah, next slide, please. Oh, I'm sorry. Just go back here. Sorry about that. Yeah. So if you look at the fiscal capacity map here, the districts outside Java Islands are struggling. There is a huge disparity between Java and the rest of the country. And for the situation, especially special transfer funds as a tool to balance out the financial conditions among regions, especially for funding the national priorities. In addition, there is a mandate to implement the national priority at subnational level. The district governments are explicitly mentioned in the Presidential Decree number 72/2021 on the acceleration of stunting reductions, that they are responsible for several indicators, including to ensure the convergence actions. So another urgency that needs attention is the disparity of the health workers' capacity at subnational level. Since Indonesia uses decentralization governance, the district government have independency to manage their local funds. Therefore, to ensure the national priorities are implemented at the subnational level, the central government has to arrange a particular fiscal strategy, so which is a special allocated funds, or we call it TAK. So this channel targets mainly the districts that do not have fiscal privilege to finance their activities. But this criteria is also integrated with other criteria such as the needs, looking at their status of stunting as well as their delivery capacity. However, the central government sets up the detailed activities or menus for these fiscal transfers to guarantee the outputs are in line with the national priorities. The purpose of this financing channel also as a catalyst for the district budgets to allocate more on their priorities. Next slide, please. So what actually are the fiscal transfers? As I mentioned, is the transfer from central governments to the sub-districts. So it goes to sub-districts especially to support the target for national priorities. So it has to be national priorities for the district to receive that transfer funds. But the detail of the activities are set up by the central governments. And then we identify the locations. What we mean by location is the district governments. And then we determine the menu and the amount of the fiscal transfers. This amount is also based on their proposals. And then we look at their need, and then we come up with the formula for the amount of the fiscal transfers. And we have a specific transfer for specifically used for convergence actions at the district level. So it's kind of an enabler. So it's not on the infrastructures or operational, but specifically for helping them in convergence of the multi-sectors nutrition approach. Can you move to next slide, please? Yeah. So this is my final slides. What I would like to show you here is the several example of the fiscal transfers menu for stunting intervention in Indonesia. There are two types of fiscal transfers that address both nutrition-specific as well as nutrition-sensitive interventions and supporting and governance interventions. So first, the fiscal transfers for infrastructures, and the second, fiscal transfers for the operational. So the fiscal transfer for infrastructures basically addresses nutrition-specific interventions, such as food supplementations, iron, vitamin A, supplements, and growth monitoring and promotions for babies and children. While the nutrition-sensitive interventions, fiscal transfers are budgeted for providing drinking waters, sanitation facilities, and family planning services. On the other hand, the fiscal transfer for operational are allocated for nutrition-specific interventions, such as local-based supplementary food, immunization services, and deworming. So basically, operational is up to the local governments how to use it, but we have provided like broader menu compared to the infrastructures. So for nutrition-sensitive interventions, the funding will be used for nutrition counseling, parenting, and then sustainable food gardens. In order to ensure the activities for each districts that come together, the fiscal transfers can be used as supporting and governance interventions that is assisting the implementation of convergence actions by subnational governments. So I just would like to add here that in addition to this fiscal transfer that is labeled as transfer for stunting reduction programs, there are also fiscal transfers for health system strengthening, which is indirectly helping how the convergence and the delivery of stunting reduction programs at the district level, such as digitalizations for and system informations. And then we also provide a menu for a higher additional health workers, as well as other related interventions such as antenatal care, maternal health, as well as primary care infrastructures. No, I think that's all my presentation. Just before I close my statement, I would like to emphasize that in Indonesia, fiscal transfers activities are integrated within the budget from the ministries. So basically, these three ministries are coming together: Ministry of Finance, Ministry of Planning, and the technical ministries in discussing the menu and the amount, as well as the amount of the money transferred to the district governments. By doing so, we are able to ensure that national priorities are implemented at subnational level, as well as complementary for the ministerial activities. Also, we can maintain the convergence actions at the districts by injecting operational funds. If fiscal transfers mechanism is an option in your country, we would like to recommend using it, especially for countries with similar issues in disparities. So that's all from me. Thank you for the opportunity. Thank you, Laura.
Mr. Punkas, thank you. And we are so grateful for your continued support and engagement and sharing all of this wonderful news. Thank you so much. I'm going to invite us to go to the next slide because we have another wonderful colleague from the field who's going to be sharing their lightning round presentation. Let me introduce to you Dr. Felix Sayunzoga, who is going to be joining us from the Maternal, Child, and Community Health Specialist Division Manager in the Rwanda Biomedical Center. Dr. Sayunzoga, we are delighted to have you with us, and the floor is yours.
Yeah, thank you very much, and thank you for this opportunity to share the Rwandan experience, but also to learn from colleagues and other experts in financing health nutrition. So next, I'll be sharing on how Rwanda has leveraged the performance-based financing scheme to improve coverage and the utilization of nutrition services in the country. So in the last 20 or 15 years, Rwanda has really experienced a significant improvement of different health indicators, and among them, the child survival by reducing significantly the under 5 mortality by 70%. This was also the same in reducing poverty levels and also increasing agriculture promotion and improving environmental health. However, we did not see the same trends for nutrition, especially among young children. And one of the concern indicator is the stunting rate among under 5 children, which is still very high at 33%. This led to the government to make a strong and a high level commitment to speed up the reduction of stunting using multi-sectoral nutrition program to ensure that we experience an increase in coverage and the utilization of high impact nutrition intervention. Specifically, the level of Ministry of Health and also targeting 13 districts with a high rate of stunting. There was a strategy of leveraging performance-based financing mechanism by ensuring you are incentivizing health providers, community health workers, but also on the other side, households and districts. Next. So the incentive is looking to motivate frontline community health workers through PBF, but also service providers in health facility using the existing national PBF scheme, but also on the other side, mothers and the children through the nutrition, sensitive direct supports doing cash transfer. But also we are providing grants to districts to ensure that they are building the capacity at the district level to ensure the implementation of those multi-sectoral approach, and also to implement their plan, the district plan to eliminate malnutrition. So to increase also that level of ownership and accountability, there is also an inclusion of nutrition indicators in the district performance that they are doing with the President of the Republic to ensure that they are also following up all those nutrition indicators. Next. Next. Yes. So the performance-based financing, especially at the service delivery point, is divided, I can say, in two types. One is for health facility, where we are incentivizing health providers through the performance-based financing scheme. We have included 11 new indicators for those districts where the projects supported by the World Bank is being implemented in order to improve the quality and the coverage of high impact nutrition intervention, and also some health intervention used by women and the children. At the level of community, we do have a big number of community health workers, around 60,000 countrywide, and therefore per village. So we are incentivizing them through their cooperatives, but also they are doing a kind of individual assessment to make sure that one who's who's performing well is also rewarded accordingly. This also has really improved the demand side, especially on key health intervention. At the community level, we have included 7 nutrition indicators and among them the community nutrition education session by community health workers, but also the screening of under 5 years children at community level. Next, these has shown really improvements, especially on key activities done by community health workers during the monthly growth monitoring, where we have seen that actually 88% of under 5 children are screening for malnutrition during those monthly growth monitoring. Next, the same on quality of services provided. You can see the proportion of women coming for antenatal care and the postnatal care who are screened for malnutrition, growing from 74% to 92% during antenatal care. And this was the same for postnatal care, going from 93 to 98%. Next. So on the other side, we are also trying to improve the demand by transfer cash to vulnerable families who have pregnant women or under 2 years children. But this cash transfer is conditioned to the use of health services, especially antenatal care, postnatal care, regular checkup of children's weight and height. And at the beginning, we had 20,000 beneficiaries. And by the end of the last year, we reached 103,000, but now the target is to reach 148,000 beneficiaries by the end of the project. To ensure also that districts are really supporting this process, we are providing kind of grants to districts to ensure that they can also implement their district's plan to eliminate malnutrition. So in conclusion, next. So the PB has really contributed to improve coverage of high impact intervention, but also at the other side, the conditional cash transfer supported poor households, families to use preventive health services. But also in addition, the grant to districts was really beneficial, especially for them to implement the district elimination plan for malnutrition. So looking on how it is being implemented in 13 districts, it is really showing that when it will be implemented countrywide, this can significantly improve and also contribute to the reduction of stunting, which the country has really committed to do so. Thank you very much. This was just the Rwandan experience.
Thank you, Dr. Sainzoga. We are so grateful for both your presentation and these informative insights. You are getting deep appreciation in the chat box from colleagues who have been listening. As promised, what I want to do now is give you all a chance to connect and to talk about this, but in a new way. We are going to be inviting you into breakout rooms in just a moment. Let me share with you how this task is going to unfold. So first of all, you are going to find yourself randomly assigned to one of 3 rooms. Now, in each of these rooms, you're going to have the opportunity to discuss the paper, as well as to connect and share insights from these wonderful presentations we heard, both from Indonesia and Rwanda. Discussions are going to be facilitated by a pre-assigned team who will lead, and you will have time to pose questions, offer insights and reflections. You're going to have 20 minutes in the breakout room to do a deeper dive on all the good information presented in this session. Now, this is important, please. If you are currently using the interpretation channels, either in Spanish or Bahasa, you will stay in this room. So if you are using interpretation, and you get invited to go to a breakout room, please refuse that invitation. We need you to stay in this room in order to access the interpretation function of Zoom. But for everyone else, if you are invited to a breakout room, please click, go there expeditiously, and you are going to have 20 minutes to actually dig in, listen, and learn from one another. With that, thank you so much. And I'm going to invite my colleague, Adam, to invite you to your space for further discussion. Adam, over to you. So I'm trusting those of you still in this main room are sorted, and hopefully you are our colleagues who are going to be using the interpretation channel. And with that, for the group in this room, I'm going to turn the floor over to Naina. I believe you are going to be leading the discussion supported by some of your other colleagues. Is that correct? So
Okay.
I'm so sorry, and I know Mira would have a wonderful value add. Hopefully we can capture that later. Please forgive me, because we do want to make sure we have time for each of the rooms to share a bit of highlights around what emerged in the discussion and in the questions. And so what I'm going to do is invite the team lead that was supporting the facilitation for each of the 3 breakout rooms to kind of give us a high-level readback, a headline, if you will, about what emerged in each of those rooms. And let me start. I'm going to start with Naina Aluwalia. I hope I said your name properly, my dear. Thumbs up. I love it. You were in breakout room 1, and I know Michelle was offering you wonderful support in that room. Can you give us some headlines about where the focus was and some of the learnings that emerged?
Thanks so much, Laura. So very quickly, we had a good overview of the various financing levers and how they can be optimized for better nutrition outcomes. And then we had a few country examples that came up, interestingly, that were not particularly featured in this presentation. And so I'd like to highlight them. One example that came up was for Cambodia, where there is an MNCH scorecard that has been added to performance-based payments. And this scorecard has also been instituted in far-flung districts where access is an issue. And then also we emphasized Indonesia's interfiscal transfers and the special funds that already we heard a brilliant presentation on, and also performance-based payments, which is sort of, just taking off on certain outcomes such as stunting. We also had an interesting example on Burkina Faso, but if for a moment I could invite Michelle to quickly
and I'm going to give you 35 seconds to give me a headline. There we go. That's the challenge.
Thanks. Very quickly, I think the comment on Burkina Faso was around the humanitarian crisis and the fact that the government is contracting NGOs to deliver services in these very hard to reach, impossible to reach areas where the government and health services are not able to reach beneficiaries. So that was the main input there, and the fact that there is very little fiscal space. So one of the challenges, and I think some of these solutions can help stimulate that dialogue in that country and others as well. Thanks.
Beautifully done and gorgeously succinct. Thanks to both of you. I am going to transition to breakout room 2, where I know we had Hirmai Dinsa was leading that room. Hirmai, welcome. And can I invite you to give me a headline, a really tight, readout of some of the highlights of your room's discussion.
Yeah, thank you so much. So we had the presentation and then a couple of questions and comments. And I'm sorry, I was just trying to improve my connection. So here is my face.
Lovely, thank you.
All right. So one question that came up and then we had a little bit of discussion about was that, is it possible to also contract or extend the provision of nutrition services to the private sector or private providers? And so we said the discussion was that yes, at least in principle, it's possible to contract the private providers. And in fact, that could be cost effective because in some areas where only private providers are available, then it might make less sense to set up another public facility, but you need to have a system in place. One of the things you need to have in place is what is the unit cost and the unit payout for providing each of the nutrition services. Do we have norms and a standard for to ensure quality and to ensure equity to extend to the vulnerable geographies and populations? And do we have a standard contract to sign the private providers? And do we have a good monitoring and evaluation system in place? So once we have those and explicitly what nutrition services to provide, to whom, which group, and how much they cost, we say that's possible to do.
I'm gonna give you 15 more seconds here, Mai, to put the cherry on the top.
Okay. So there is also a comment or a note from UN Nutrition that I think Kate is going to share a link that countries can use to apply for nutrition improvement programs. Thank you.
Wonderful. Thank you so much, my friend. And last but not least, we had breakout in room 3, where I think the team lead was Huiwei Wang. Huiwei, please, can you give us a nice headline on your room's discussion? Huiwei, we cannot hear you. There you are. Yes.
We had a rushed but quite exciting discussion. A few highlights. One participant made a comment that nutrition has to be delivered with the PHC platform. We cannot single out the nutrition and to create further fragmentation, which I thought is an excellent comment because that's all the intention we're doing it. Sometimes we give nutrition examples. It makes give an impression that we're only talking about nutrition, but really that's the point of put IFA as a part of the antenatal care, for example, right? And the second point, the question was raised for Indonesia context. The participant was interested in how Indonesia was dealing with sometimes, oftentimes overlapping programs. We couldn't answer for Indonesia. They are going to follow up offline, but we did reflect that, in many countries, the situation is fragmented. You have a lot of overlapping, but they don't really pick together. So that really emphasized the importance of pooling, right, and the data information system. So I thought that was a really important reflection. And,
wait, I'm going to give you 15 seconds to go ahead and land the plane.
The third reflection is accountability. So accountability is important. Health financing levers can promote accountability, but we need to understand the dynamics of providers and the service users, why accountability didn't happen in the first place before we even apply solutions. So I thought that's also a very good reflection. So 3 points. Thank you so much.
Wonderful. And thanks to all of you for both being so succinct and sharing back with us what you took away. We're going to bring the session to a close. We've got just a few minutes for Samil Nagpal, our senior health specialist from the World Bank Group, to kind of put the summary on top of everything and to preview what tomorrow holds. Samil, we turn the floor to you.
Thanks very much, Laura. And it has been an absolute privilege to be in this session. What a fantastic discussion. Clearly showing that health and nutrition are so closely intertwined and synergistic, and a lot of things that we are sometimes working in separate silos need to just come together, and some of that has very well been demonstrated by this discussion paper as well. I completely agree that some of the most impactful nutrition-specific interventions are best delivered as part of an integrated set of maternal and child health services by primary care facilities. And so the agenda for PHC-oriented UHC is not very different from how the health system can contribute to nutrition by itself. So many of these best buys in nutrition, on the other hand, also have additional MCH and broader UHC benefits. So we need to really focus on how we can bring the two closer together. There was a very interesting discussion, including in the breakout rooms, on performance-based financing and many of these innovations. And I really feel that as long as we can make sure that some of these high return nutrition investments remain on our radar and we can use systematic priority setting processes, we will find that more and more of these services are more explicitly included in what UHC programs have to offer. So what would this integration of nutrition and UHC mean as we go forward? That it is part of an explicit benefit package. There is clear priority setting that leads to the demonstration of the value that the nutrition services bring, and that's clearly included. It is delivered as part of a good quality set of health and nutrition services as an integrated whole. And the quality aspect, when applied to, say, antenatal care or immunization, would then include the dimensions which get even more important to achieve the nutrition outcomes that we need out of these common services that the health system provides. And finally, and very importantly, I think it has to be sustainably, efficiently financed, and it has to be well accounted for. We discussed the UHC monitoring report, and a very interesting concept that Kyoko-san presented was, though we do not have explicit indicators for nutrition included in the UHC monitoring framework, there are still many things there. We have antenatal care, and we have immunization, and we have non-communicable diseases as part of the service index that is used in the UHC monitoring framework. How do we tease out the nutrition part there? And the idea of a nutrition lens, try to look at this and break it down and look at those same indicators with the nutrition lens and filter out what the world of nutrition would want to focus and highlight attention on, and probably supplement that with some additional information on services that may not be part of what already is being captured. As currently done, UHC monitoring framework is a set of tracer indicators. So it cannot feasibly include every single health and nutrition service, but it does include a whole lot that is currently in a more, let us say, combined form, and we need to find this good nutrition lens to look at it. So I hope that we can work on that further. I'm very excited at opening this topic for discussion. This has been a dream for many years, actually, I would say, with Meera, to see how we bring this issue of nutrition financing to the mainstream discussions in UHC, and delighted to be part of this whole exercise and this event. And I think the world of UHC will also gain. This will be one way that we will learn how we operationalize social determinants of health, how we look at things with multiple lenses and keep the value of the UHC monitoring framework. So big thanks, an excellent set of presentation. Papunkas and our colleagues from Rwanda and Burkina Faso had some excellent contributions. I learned a lot, and I hope that we can continue this discussion, this being a very good start of a very important thematic area of focus. Thanks very much. And it's back to you, Laura.
Thank you, Samil. And I just want to remind everyone, we're so hopeful we will see you tomorrow. We have a couple of wonderful sessions. Please remember our session 3A, the fizzy potential of fiscal policies for nutrition, how taxes and other tools can encourage healthy diets, starts a bit earlier than we did with this session today. So it's going to begin at 7 a.m. Eastern Standard Time till 8:30. Then it will be followed by our second session for the day tomorrow. I want to appreciate every one of you. It feels like there's never enough time, but with the time we did have, what a marvelous use you all made of it. With that, can I ask us to take the slides down? Let's go to gallery view. And if in fact you have the bandwidth to turn your webcam on, please, let's all say goodbye and maybe say see you tomorrow. And thanks to everyone, all of our presenters, all of our contributors and all our participants. Thanks, everyone. See you soon.
See
So
you soon.
appreciate
Thank
you.
you.
Take good care.
Thank you very much.
Bye.
Thank you,
See everyone
Dr.
tomorrow.
Felix,
Bye,
Dr.
friends.
Papungkas.
Thank you very much.
Thank you,
Thank you,
thank you.
Thank you to the
everyone. Thank you,
presenters.
thank you.
Great session. Thank you all. Bye.
Bye, everyone. Take good care.